talk about some topics that have been emerging in ureteroscopy in the past couple of years that I think are becoming more and more exciting. If we think about how we perform ureteroscopy for treating stones, we always want to do better, and we always want to improve. And if we think about what are the opportunities for improving our technology and our procedures right now, that includes doing surgeries faster, being more efficient, reducing postoperative pain, question about whether or not to use a stent and what kind can play into that. How do we lower our complication rates, whether that's pain coming back to the ER or infectious complications. And then finally doing a better job at removing the stone and potentially looking at stone-free rates. So some of the topics that have emerged in recent are single use and better ureteroscope designs, and then pressure, temperature, and suction. And so I'm going to focus on the bottom three today, just to give you a flavor of what's sort of coming, which I think we're going to see more and more of in the near future. So first, shifting to pressure. This is an example of a kidney that suffered from high intrarenal pressures and caused basically a rupture. But we know overall, if you look at thousands of patients and multiple data sets, ureteroscopy carries about a 5 to 6% risk of urosepsis. The use of ureteral access sheaths can reduce that risk significantly. Larger sheaths, also smaller ureteroscopes, pretty much anything that allows fluid to drain during the procedure, both lowers sepsis but also lowers intrarenal pressures. And a study by Dr. Manga had found that during PCNL, higher pressures are associated with greater postoperative pain, hospital stay, and SIRS. So there's definitely a correlation there between pressure and infectious risks and possibly pain. And there is data to show that bacteria in a high pressure environment increases your risk of sepsis. So in that PCNL study, if you put bacteria into a pig animal, into a live pig, and subject it to high pressures and then dissect the organs later, you can actually see the bacteria have been translocated to different organs. And we know that the threshold for pilovenous backflow is somewhere around 30 to 40 centimeters of water. So if your pressures routinely are above that during ureteroscopy, you're at risk of displacing bacteria, if there is any, and causing infectious complications. And actually the AUA guideline statement this year, the new update has a nod to that by saying clinicians should make every effort to maintain low intrarenal irrigation pressures to reduce these complications. So how can we control pressure? Certainly if the patient has a nephrostomy tube in place or some way we can vent the kidney during the procedure, that certainly can be a role. Larger ureteral access sheaths, so 12-14 French or larger has been shown to have a significant reduction in intrarenal pressures. 11-13 Frenches are a little controversial depending on the size of your scope because there's not enough room around between the scope and the sheaths potentially to enable drainage. Intermittent scope removal. So there's been some modeling studies. If you use a ureteral access sheath and you take your scope out periodically, that actually will allow the fluid and the intrarenal pressure buildup to vent out. And finally, controlling irrigation. In this data study, you can see too that the use of a 12-14 French sheath versus no sheath had a significant difference in intrarenal pressure from 16 all the way up to 50. So significant pressure increases. How do we control irrigation? Currently, we can use an automatic infusion pump. These are becoming more commonly used. I use one in my hospital. It's very great and easy. You just have to know the caveat that they're not precise when you set either a flow rate or a pressure. They may underestimate or not be as accurate because they measure their system based on real-time flow rates, and they don't have a way of measuring true intrarenal pressures. You can use pressure bags, you can use hand irrigation, and again, beware of who's working the hand irrigation system. If you have a strong resident doing it or a PA or someone who's less experienced, you can really create some significant pressure rises even though you don't feel like you're doing it with the pump. And now we have a new technology that enables intrarenal pressure real time. So there's a new single-use ureteroscope out called the LithoVue Elite by Boston Scientific, which has the capability of measuring intrarenal pressure. This is Ben Chu doing the first case in humans using the device, and Naeem Bajani also doing a case using this. And you can see that you can really monitor real-time the intrarenal pressures, and you can see a significant difference when Dr. Chu is doing it using a ureteral access sheath versus without. You can see the intrarenal pressures are usually in the 20s millimeters of mercury on the left, and without a sheath, with his irrigation system, it's consistently much higher, almost as 80, 90, or even 100 millimeters. So I think with this tool, we don't know a lot about it yet, but you can imagine where we can potentially change our behavior and what we're doing to really make sure that those pressures stay low, particularly in a patient who may be at high risk for infectious complications. At UCSD, we are actually doing research on the same topic, and so we've been, before LithoVue Elite came out, we've been using a Comet wire, which is developed for cardiology, but it's a pressure sensing wire. So we're actually placing it in the kidney as our safety wire during ureteroscopy to measure intrarenal pressures, and we're now actually correlating it with LithoVue Elite, and we're finding that it correlates very nicely. But just kind of a brief take home is on the left here where it says baseline. That's the pressure we're finding, intrarenal pressures, immediately after placing the wire before we put a sheath up. And then after we put in a sheath and are performing lithotripsy, the middle column is the pressure. So it's interesting to see, just because, after some of the activity like shooting a retrograde causes the initial pressures to actually be in the 20s, whereas now we're realizing if you don't shoot a retrograde, or depending on activities that you do, you can really have some effect on that pressure. And also significantly, the use of a 12-14 French ureteral access sheath or larger, you can see a significant decrease in the average pressure there between the blue, orange, and the gray. So ultimately our goal is to use this information to help control how we do the case and reduce risk. Moving on to temperature. So the kidney is like any other organ, and unfortunately, if you subject it to high pressures, you can cause injury and burn it. And it turns out 43 degrees is that critical temperature, where above which you get denaturation of proteins, and you can get cellular injury if you expose the tissues to that temperature for too long of a time. And there's this concept called the T43, which is the time, sort of the reflection of the time that the kidney is exposed to these cytotoxic temperatures. So obviously you want to minimize that time, or ideally avoid it. This was a study where they fired a laser at 40 watts, 0.5 joules, and 80 hertz for 60 seconds in a kidney with varying amounts of irrigation. And you can see with no irrigation, the kidney get cooked all the way to 85 degrees Celsius very quickly. If you add significant irrigation, you can keep the kidney cool. So even with room temperature irrigation, you can mitigate that effect. And so one take-home point is always use irrigation when you're running a laser. This is a really nice study out of Irvine where they put thermal-coupled temperature sensors into different parts of a porcine kidney during a live surgery. So as a anesthetized pig, they also had a temperature sensor in the ureteroscope. And then they fired a laser at various settings shown here. They also used a single or a dual lumen ureteroscope. And then they looked at warm temperature versus room temperature for irrigation. This is a busy table, but I think the take-home point is the deeper the red, the higher the temperature. And you can see that in the group that used warm irrigation on the dusting settings, resulted in the highest intrarenal temperatures. And even with room temperature irrigation on dusting settings, it resulted in higher temperatures. They also used a dual lumen ureteroscope, which potentially has a second channel, so it may help with some additional drainage, and that seemed to lower the temperature. So take-home points is if you can use a sheath, if you can use room temperature irrigation, not warmed irrigation, and then if you have a dual lumen ureteroscope, these are all ways you can reduce the temperature by enhancing the flow. And then also dust with caution, and we'll come back to that. Turns out how you fire the laser can play a role too. So there's a term called the operator duty cycle, which is what percentage of time is spent using the laser. But you can imagine if you fire the laser for 30 seconds continuously versus 5 seconds on, 5 seconds off, 5 seconds on, you can get a different temperature profile curve. And so in this study, they basically ran a 40-watt laser for a total of 30 seconds. And they either did a continuous 30 seconds where you can see the temperature goes up very high in this graph, or they ran it 15 seconds on, 15 seconds off, or 10 on, or ultimately 5 on and off. And they kept cycling until they had a total of 30 seconds of laser time. And you can see over here that the time to the threshold of thermal injury was significant when you run it at 30 seconds or even 15 seconds. But if you only run the laser 5 seconds on, 5 off, the temperature never gets high enough that you're subjecting the kidney to dangerous levels. So certainly if you're concerned about temperature, or if you're using, say, a TFL laser with a high hertz frequency dusting setting where we know can generate more temperature, that's something to be aware of. Now back to TFL, there's been a lot of concern, if we're running at a dusting settings of say 0.2 joules and 500 hertz, that extra hertz potentially causes more thermal injury into the water. Does that translate into injury? And I would say the data is inconclusive. So this is a study that basically looked at that. They ran the TFL versus a P120, 120 watt holmium laser at a variety of settings. And you can see that they're matched in terms of wattage. So for the dusting settings, they both were around 20 to 21 watts. And they found that the temperature increases of both were comparable. So in the dusting settings, importantly, the temperature did increase all the way to 41 degrees versus 29 degrees in the fragment settings. So certainly that higher wattage will translate into higher temperature. But in this study, they found there's no difference between the actual laser itself. In contradiction, this study found that running the TFL compared to the holmium at the same settings did cause higher increased temperature. So this is a 3D printed model of a kidney submerged in a body temperature fluid bath. They had a Bechis stone in the ureter, and they basically fired a laser at different wattage settings to treat this ureteral stone, and then they looked at the temperature change. And you can see here in the thulium fiber group, regardless of the energy, whether it's 3.5 watts, 10 watts, or 30 watts, the temperature increased significantly greater in the thulium fiber group. Now this is in the ureter versus the kidney, so perhaps that is at play here with less irrigation. There's more, the ureter is more sensitive to temperature changes. So the take-home point is, especially in the ureter, really being cautious to keep your energy levels low. So how can we control temperature? So there's a few ways we can use a ureteral access sheath. I'm a big fan. I pretty much use sheaths most of the time because I want to minimize pressure and temperature as much as I can. Making sure you're running irrigation with the flow on. If you're concerned, you can run a shorter laser activation cycle, and then also really keeping your energies as low as possible, particularly in a space such as the ureter. So moving on to suction. So I'm sure many of us have seen this scenario where you might be fragmenting or trying to dust a stone, and it really doesn't dust into the small particles you're hoping for. You get these kind of bigger chunks. This is magnified, so they look even scarier. But if you have this big pile of stones and you're thinking to yourself, geez, I really don't want to have to basket all of these out. This is going to take forever, and the laser isn't working any further. Wouldn't it be great if you could find a way to suck all those out like a vacuum? And sure enough, we now have some devices that can do that. So probably the one with the most data that is commercially available is called the CVAC aspiration system. And this is essentially like a flexible straw. So it's a 7.5 French inner lumen and a 12 French outer lumen. And between the two lumens, there's irrigation of fluid comes out. And then the stone particles are vacuumed out through that inner lumen, and they can be up to 2.5 millimeters in size. So it's a pretty significant size you can remove. This fits through a typical 12, 14 French ureteral access sheath. And then it has a hand irrigation system, and it's steerable. So you can actually manipulate and direct it, and you can see it under fluoroscopy as shown on the right, so you can really follow where you're directing it. So this is a quick video. showing how it works. So you can imagine in this patient, there's stones in multiple calyces. So first, we're putting up the ureter access sheath. We'll perform ureteroscopy with laser lithotripsy to fragment or dust these stones into smaller pieces. And the nice thing is if you aim to get them all, around 1 to 2 millimeters in size, then pretty much over the wire you can advance this, the CVAC device. And then under fluoroscopy, so you'd perform a retrograde, and then under fluoroscopy you can direct this catheter into the calyces of interest where you know that the stones have been left. And there's a hand irrigation system, so you're continuously flushing fluid out, and then it's being aspirated in through the inner lumen. And then, as this is going, and then once it's done, all the stones are collected in a canister. You can then put your scope back in. If there are residual stones, you can then do this procedure a second time. But it's pretty neat. It's very efficacious. And now there's data behind it. So the first initial study was published. There was a randomized controlled trial of 17 patients. And you can see that basically they looked at CT scans on day 1 and day 30 after the procedure. And it's actually pretty impressive. You can see that by day 1, the percent of stone volume that was removed in this group was 84% versus 56% in the basket group. And if you look at the 30-day CT scan, and CT scan I would argue is the kind of the standard of care for considering true stone-free rates, 100% of patients were stone-free by 30 days compared to 75% in the group where you left dust behind and hope that they'll pass it. Granted, this system does use increased fluoroscopy exposure, and it does lengthen the procedure time slightly. I've done it personally on patients with 2 to 3 centimeter stones who were not candidates for PCNL, and I've been very impressed with the results. And now there's data to support that as well. They looked at a second study, looked at patients with larger stones greater than or all the way up to 4 centimeters worth. And you can see this is an illustration showing what the calyx looks like after all that stone has been sucked out. And in this study, you can see even in that third column, which is stones greater than 3 centimeters, they had 94% stone clearance. So it's very effective for removing stone volume. Another device that's on the market is called the Cleopatra ureteral access sheath, so I think it's worthy of mention. It's a deflectable sheath. You do have to bend the ureteroscope inside it in order to enable it to flex, but then it serves as its own access sheath, and then you connect irrigation and suction to that. And then there are a few other devices that are coming out. So there's this device in China called the FVUAS, which is similar to 1214 French passively bending device. And at least in this early report that they reported 70% of patients were 100% stone free. And then finally, there's a case report that came out also from China of a different device that achieves the same goal. It's a deflectable vacuum type device that is actually controlled by the handle. So I think there are more devices coming out on the market. I think people have recognized this area has great potential, especially if you couple this case with a laser that creates very fine dust, you can really vacuum out these stones very quickly. If you have patients who aren't candidates for PCNL, or you have patients who are very sick and have comorbidities, and you really want to offer them a quick procedure, ureteroscopy, where you can then remove as much stone as possible, it's been very, very successful. Obviously, there's room for improvements as they develop new technologies. A main limitation of this is that right now, it's done under fluoroscopy without visualization. But I imagine that these advancements are coming in the future. So thank you very much.
Thank you.